still remember my conversation with the advisor. She looked at me dead in the face and said, "What do you want to do with your life after engineering?" And I told her, "I'm starting to think about wanting to go to med school." And she looked at me and said, "If that's the case, get out." I think I was seeing my attending physicians who are, in their 50s and 60s be on call during the holidays, during the weekends. There's a tremendous amount of sacrifice that comes along with that. How do we change these habits? How do we change entrenched systems of care and delivery of care that's been going on for decades? If we could arc an entire patient journey and then talk about some of the levers or what we call systems factors that influence that patient's care along with the clinical medicine that they're receiving, this would be a really cool thing to do. So the first half, we talk about all the underlying root causes. The second half of the book was actually talking about, now what can you do about it within your own practice of care?
Welcome to Your Future in Sight, a podcast where we showcase stories featuring doctors and other healthcare professionals early in their careers.
We'll take a deep dive into their day-to-day lives, focusing on how they navigate the current landscape of medicine. Each story is personal, captivating, and uniquely crafted by their individual perspectives and experiences.
In each episode, we'll discuss their challenges and aspirations, and most importantly, their journey to give us insight into the future of medicine.
My name is Andres Parra.
And I'm Gio Campagna.
And we are your bro hosts, two friends turned ophthalmologists who enjoy learning from our peers. Let's get started. In today's episode, we will be talking with Joseph Ju. Joseph is an internal medicine physician and faculty at the University of Washington, where he also serves as the Director of Program of Policy Evaluation and Learning in the Pacific Northwest. Through the program, Dr. Ju directs a leading policy unit that applies scholarly expertise to partner with decision makers on pressing policy topics in healthcare. His professional interest in healthcare systems at large was fostered during an internal medicine residency with a distinction in care transformation at Dell Medical School at the University of Texas at Austin, followed by his Master of Science in Health Services from the University of Washington. His most recent achievement is publication of an illuminating book entitled Reshaping Health Systems: What Drives Healthcare and How You Can Change It, which he intends to discuss with us during today's podcast.
All right, Joseph, thank you so much for joining us on the podcast today. We are really excited to have you on. Why don't you start by telling us a little bit about yourself, a little bit about your background, and ultimately what made you pursue a career in medicine?
Well, first of all, thanks guys for your time. It's good to see you guys both. And I am a general internist currently in Seattle, Washington with the University of Washington, but I am originally from Texas, the great state of Texas. That's where I went to undergrad and did most of my training and did my intern year with Gio. So that's how we know each other and spent a lot of time in the hospital wards together. I originally had no idea that I wanted to go into medicine. I actually was an engineer at first, or wanted to be an engineer. So went to engineering school. And then a couple of years in, I still remember my conversation with the advisor that Gio probably had as well, is she looked at me dead in the face and said, my advisor, "What do you want to do with your life after engineering?" And I told her, "I'm starting to think about wanting to go to med school." And she looked at me and said, "If that's the case, get out."
Oh, wow.
and her reason behind that, to her credit, was that she knew the game of medicine where the number one thing that schools look for is a high GPA. And there's a difference between having a strong academic record as a pre-med wanting to go into medicine versus perhaps having a strong GPA for what we considered a strong engineering application for any jobs coming out of college. For example, let's say, I think majority of my buddies would have said, if you graduate with a 3.5, 3.6, 3.7 coming out of engineering school, that would be very, very competitive for most jobs. Whereas, as you guys are just as well aware, some of the most competitive schools, that's kind of the average, if not maybe on the lower end, depending on which schools you guys are talking about. And so I took her advice. It was a very sobering moment, but I took her advice and said, okay, and actually was able to kind of get out of the engineering program into taking some classes in the natural sciences, the liberal arts. So along with your physical chemistries, your biochemistries, I was able to take some economics courses, some business courses. And that's when I actually first was able to start balancing, if you will, or get into the rhythm of thinking about the details of, sciences along with the arts and the stories and the economics and kind of the holistic part of what goes into medicine. And that's the mindset that I had, fortunate enough to get into medical school, and then going into thinking about what career do I want to pursue within medicine. I found internal medicine to be kind of a right balance of that, where not only am I thinking about the sciences of how to treat a certain disease, but oftentimes just as important, if not maybe more important, is to think about the setting of care, where someone's coming from, what kind of background or setting they're going to be going to after discharge. And I thought that internal medicine was a good career to be able to think about a number of those factors and the complexities of all that together. And so that's where I am today, practicing at UW.
Wow, that's potentially, I mean, what a serendipitous thing to have your, advisor tell you that. And of course, she's playing the numbers. She's like, I want my students to succeed and get into medical school or whatever it is.
Exactly.
But that strong nudge just pushed you in a direction that would change your career for the rest of your life. And so that's actually a really fantastic way to hear. I've served on admissions committees for scholarship programs, for medical school, for residency programs. And to hear a story that cohesive really tells me this guy really wanted to do internal medicine for the right reasons. And so it's cool that, you got to do, like, you have to think about all these social factors when you're in internal medicine. You have to think about disposition. In ophthalmology, when I send someone from the clinic, I don't have to worry about like, well, do they have, someone at home who's going to help them administer the medications, or someone who take care of them, or do they have a ride home, as much as, internal medicine might do when someone's, admitted. And so that's really interesting to hear that that's your backdrop for wanting to do internal medicine. I hear so often, and I know Gio and I are the same. We've had a lot of friends that, go into internal medicine thinking specifically, I want to do cardiology, I want to do GI, I want to do some of these other subspecialties within internal medicine. Is that something you ever considered? Was that, did you always have a different kind of career path in mind, or what was your kind of thinking as you were going through, your residency?
Absolutely. I was fortunate to train with a lot of great subspecialist attendings. So definitely cardiology, wanting to be a cardiologist was on the radar. But I think a few things crystallized during my second year of training. Number one, how often cardiologists are on call, especially, interventional cardiologists. I think I was seeing my attending physicians who are, in their 50s and 60s be on call during the holidays, during the weekends. And the kind of the toll that it takes on the rhythm of balancing a lot of the important things in life. I realized, wow, it is interventional cardiologists, we need them all. We need as many of them as possible. But I realized there's a tremendous amount of sacrifice that comes along with that. And so that's when I was actually first introduced to this idea of, different style of work and rhythm, whereas being on call is one way to do it. Shift work is another way to do it, where exactly whether it's, 12-hour shifts or 16 hours or however long a shift may be, when you're on and when you're off, right? And I thought that was a model that better suited the type of work that I want to do. And then one of my really close mentors of mine, Chris Moriades, who was kind of the first one to tell me of this model called like the systole-diastole model, whereas I think that kind of really exemplifies the hospitalist work rhythm, where systole, it's the active work cycle where you're on, let's say, for 7 days straight, right? And then the diastole part, or as people frequently, the 7 off, is diastole is often thought of as like when people, it's still proactive rest. It's not just complete inactivity, but rather it's when, the heart refills in preparation for the systole, right? And so that was the way that...
That's the most internal medicine analogy I've ever heard. That's coming from two ophthalmologists who live in diastole, I think.
Yeah.
So.
Yeah, and I heard it for the first time and I was like, shoot, I've never thought about it in that way. But it was Chris's way of kind of crystallizing his rhythm, his work-life rhythm that he had built, where he is, at the time when I was in Austin, learning from him, he was the assistant dean for healthcare value. So a lot of the time that he spent on the wards or teaching students or residents was considered, if you will, systole. And then his diastole was a lot of the work that he was doing with graduate medical education, undergraduate medical education, teaching students, teaching residents like myself to think about healthcare system factors and delivery factors, and going back and forth from that and seeing him and having the opportunity to watch that up close gave me this idea that not only could I see patients and think about their complexities of discharge, as you mentioned, and all the number of subspecialists that we need to coordinate care, but also think about when I'm not seeing patients, thinking more at large, at a higher scale, at a macro scale, to say, what are some of the real, levers that could possibly change this at a regional level, city level, state level, or national level even. And that's kind of how I thought about I wanted to evolve in the rhythm of my work, which is ultimately the reason I decided against pursuing a clinical fellowship like cardiology or gastroenterology, and decided to do a little bit different postgraduate training on my own after internal medicine.
Yeah, I think that's actually a perfect segue to the next question I want to ask. And real quick, I will also give a shout out to Dr. Moriades. I also worked with him. Joseph and I were co-interns together.
That's right.
At Del Seton Hospital at the University of Texas, and we worked with some of the same people. So I also got to indulge in some of the same professional influences that you had. And on that topic, I'm kind of wondering, are there any specific maybe patient encounters you can remember or experiences with clinical cases that kind of really helped to drive this point home that you didn't want to go pursue a traditional, cardiology fellowship or gastroenterology fellowship? Do you remember any specific, interesting cases or scenarios where it really clicked, like, I really need to do something a little bit non-traditional with my career?
Absolutely. First of all, Gio was hands down one of the smartest people I've ever worked with.
I paid him to say that.
I believe it. This is true.
It's scripted. It's all scripted.
We were actually on the same team a number of times, and those are some of the most fun times I remember sitting next to each other on the computer, writing notes, thinking to ourselves, what are we doing right now?
Well, especially what was I doing at the moment? But you and I finished on internal medicine together. That was my last rotation of intern.
I remember. And it's actually, during some of those times when at first I kind of tilt my head and ask this questions such as, why in the world do we still use pagers and fax machines in the hospital? When, I would have friends in different industries who would tell me their work is giving them phones to be able to communicate, and all the different, messaging on the phone apps now that are secure message that we could have possibly used in the hospital. But I think Gio and I were holding our pagers and then asking ourselves, like, what is this thing from the 1980s that we're still using in the hospital?
It's often overwhelming, isn't it? There's a ton of different ways to reach somebody. You can call them, you can page them, you can text them, you can instant message them, you can call
You can make them wake up into a cold sweat with this beeping of the PTSD that is induced by the beeper. Yeah,
it's excessive.
And as you guys probably know better than anyone else, I mean, it's oftentimes you're wearing more than one pager, depending on which service you're on.
I've learned 4.
You'll see someone walking down the hallway with 4 on their belt, right? And I was asking myself, why do we do that? Why do we still fax things and blindly believe that someone on the flip side of the fax machine is going to pick up some really, really important document that insurance requires for them to be able to get a medication or get some service at home? And another question that I had was, we spent so much time being trained to think about writing a good discharge summary, because the idea of a hospitalization is that, yes, we do our best to make sure they're being treated for the right diseases that bring them into the hospital. But oftentimes, let's say a COPD exacerbation or a heart failure exacerbation, we're kind of putting a stopgap or a Band-Aid on the immediate exacerbation, but the recovery is more or less happening at home once they return back. And longitudinally, getting the right inhalers, to getting the right medications, to getting the right diuretics and all the heart healthy medications, all of that is longitudinal at home with our outpatient physicians and clinicians. And I think we were scratching our heads at one point thinking, we spent so much time writing this instructions, the follow-up to-do items for Dr. So-and-so, and once they leave the hospital. And I think I still remember one of the students asked, like, how often do you think someone reads this once we send this or press send or sign on the computer? How often do you think someone on the flip side is reading this? And that kind of stopped me again, dead in my tracks, to think to myself, I have a blind faith that this EMR that I'm working on, or printing out something or faxing something, someone's going to pick it up on the other side in a very coherent, connected system, within a time frame that is very, salient, whether it's a week or 2 weeks, and the person will be able to carry out the plan that I carefully wrote in this. That's a lot of faith on the system. That's a lot of faith on the person on the other side to understand, hopefully, what I was able to put on a piece of paper or on the computer. And these kind of questions started coming about actually when Gio and I were together working our first year of training. And that's when I started kind of logging them in the back of my mind slowly. Some of them I wrote down, some of them I just would ask over coffee in our break room, or late at night when we're in the hospital and looking over to my senior resident or looking over to our chiefs and saying, like, hey, how does this work in real life once you're outside of this training environment? And I think those are some of the questions that I think I still remember to this day, where I was like sitting down in some of the nursing stations thinking about this.
Well, it seems like you're definitely very conscientious about these things. And I think about it, think about the number needed to treat. Like, what's the alternative? We don't take the time to write these discharge summaries. I say we, even as a resident, writing these discharge summaries, even if, out of the 10 that you write, one PCP gets it and is super grateful and is able to continue this care longitudinally. Or think about how many people, when this patient gets readmitted, something happens, gets a readmit, and someone has to trudge through all these notes, and they have a beautiful, clean discharge summary to look through to kind of help continue this care, in a great fashion. That in and of itself is really worth the work. And so I commend you for, it seems like you've been thinking about systems and how systems apply and how you can change things. And anyone who's been in medicine for longer than 5 seconds knows that change is hard. Changing an EMR is hard. Changing habits is hard. Just on a personal level, changing habits is a very hard thing to do. And so you're challenging some of the status quo, saying things like beepers, are outdated. It's hard to make those kinds of changes. And honestly, it's not easy. And so that's why I think probably a lot of people don't take up that mantle. And so I want to know, it seems like this is the way that you think. You sought out a specific program. You said it wasn't like the usual clinical programs in terms of fellowship that you look for. What is it specifically that you found in terms of fellowship? How did it differ from a clinical fellowship? How many of these kinds of programs are there available? And then what were you seeking to get out of it?
Yeah, absolutely. I, around PGY2, end of PGY, second year of training, kind of going into the fall of our third year of training, was really wrestling with this exact question. I want to be better versed in thinking about things at larger scale, not just one delivery system, but maybe at a regional level or at a state level, which kind of naturally brought me to this point of the nexus of policy and realizing that regional policy, state policy, federal policy has such an influence on the day-to-day of what we are able to do as clinicians and what we can't. And one of the biggest drivers, let's be real here, is how physicians and healthcare systems get paid, right? Payment is, I believe, one of the strongest incentives and motivators and drivers of how the healthcare system works. And I think the longer I've done this, it's a sobering thing again, but it needs to be said. And I think I was feeling the brunt of that PGY2, PGY3, thinking about how do we change these habits, as you're mentioning? How do we change entrenched systems of care and delivery of care that's been going on for decades? And so I started asking around to my colleagues, where could I learn more about how health policy is made? Where can I learn more about how payment models and how they influence some policies and kind of all of that reciprocate and really come to interaction and fruition with one another along the legislative cycles? And I started asking around some of my colleagues, and what I found was twofold. One, no formal, or as one might say, no ACGME accredited fellowship kind of existed for this. I think the majority of those, if not all of accredited ACGME fellowships, are mostly clinical fellowships. So I started kind of looking into non-ACGME accredited, and I know that kind of sounds off-label, but I think, for example, one of the examples of a non-ACGME fellowship is like the hospitalist fellowship, where after 3 years of internal medicine training, one could decide to pursue an extra year or two to think about becoming a hospitalist from maybe an administrative perspective, wanting to really dive deeper into the quality incentives, the safety aspects of inpatient care, outpatient care. And I know several of my colleagues who've done such fellowships and then gone on to become, assistant or associate medical directors of units of hospitals or intensive care units, and then go on to become, director of quality and safety at some care delivery systems. Another way that I was thinking about it was really kind of ad hoc, piece by piece, putting a fellowship together myself. And I know that sounds weird for me to say, but I think what ended up happening was I was really curious about how health policy is made at a state level and at a regional level. And there were very, very few people that were doing this and well-versed in thinking about payment models and payment systems and how those nexus come together. And it was around this time, it was actually through Dr. Chris Moriades. He reminded me and reconnected me with a colleague of mine who formerly was actually at UW. His name is Josh Lau, who is someone that was right at that nexus that I was talking about. He was very, very well associated and connected with the Washington State Healthcare Authority, which is the biggest purchaser of insurance in the state of Washington here. and oversees care for many of the Medicaid beneficiaries here in the state. And then also was a payment model expert. And especially more specifically, when I was coming out, he was a bundle payment, alternative payment model expert, where he was really thinking about surgical bundles, knee replacements, hip replacements, cabbages, your PCIs, and defining a bundle of care, and then thinking about how we pay clinicians and care delivery systems based on a bundle of a hospitalization or all the things that come along with that, instead of, fee for service, paying for everything piecemeal. And so I started talking to Josh and said, these are some of my interests. I don't know that very many people do what you do, Josh. I would love to learn more about how I could be better versed in this. And then Josh kind of looked at me and said, if you really want to learn this and learn it well, I don't know that there is a formal training program, but if you're willing to kind of go on a little bit of a leap of faith, we could try with some of our general internal medicine faculty here at UW and the School of Public Health that we have, one of the best schools, I think, School of Public Health in the country here. We have a lot of faculty in the Department of Health Systems and Population Health. If we could, piecemeal a number of these things together and then have you see patients at multiple sites of our clinical system here and organically put this fellowship together, it's going to require a lot of work, a lot of initiative on your end. But if you're willing to do this, I'm willing to go back for you and try to put a program like this for you together for about 2 years. And I remember getting off that phone call going like, what did I just talk to this guy about? It's like, because it was the complete opposite end of the spectrum where, let's say if I was applying for a cardiology fellowship, you know exactly. So structured, you know exactly what application cycle looks like, the forms look like, when to apply, who to talk to. Whereas this was very organic. I spoke to Chris. Chris kind of connected me to this guy here at UW, Josh, and then we talked about if you were to take, a pie and divide up your time, and what would be the most meaningful to you? How much time would you want to spend seeing patients? How much time would you want to see how the legislative session works here in Washington State? How much do you want to get into the nitty-gritty of how claims or Medicaid claims work in the state of Washington? Do you want to do, a project where the state has actually asked us to help advise on a specific bill coming up, and they want a clinician's perspective on the validity and the evidence behind what they're drafting? Do you want to have a say in this or a part in this? And then with our faculty here in the School of Public Health, do you want to go take some courses? Do you want to go learn about the methods that really go into driving how payment models are made and all the calculations that are done behind the scenes, the nitty gritty? And I said, if we can make the math work, the time work, and I was fortunate enough to where I could have the flexibility to kind of move across the country and take a leap of faith in this. And Chris really encouraged me again, said, this seems like a very interesting and a unique opportunity, and let's give it a try. And so it's been really, really cool. And I'm at the tail end of that kind of training now, where I've had a influx of experiences that I don't know that it's very, very replicable, but I'm really thankful for all the different things that I've had a chance to work on with a number of faculty and clinicians here all at UW.
That is a really terrific answer. And I think that a lot of the things you're saying are going to resonate with some of the audience, and let Joseph be an example that you don't have to do the traditional path. You can forge your own educational pathway for yourself. Sure, it does require a little bit of creativity and some bravery, but if these concepts are really, really important to you and you don't want to have to shoehorn them into your traditional fellowship, you can make your own experience. And I think you've done a really, really great job of doing that.
Especially coming from a background where, in medicine, we're taught everything is structured. You apply to college like this, and you apply to medical school like this, and then this is XYZ. It's all so linear. So really commend you for doing something that seems like should be part of the curriculum for every single physician out there. We should all know these things, honestly. With the fact that so many of us navigate with our hands in the air, just walking around like this without really knowing the full landscape, is honestly really eye-opening. And so
going against the grain is certainly something that is hard to do, but very impressive nonetheless. And one of the accomplishments you've achieved during this fellowship is that you've become a published writer And we want to give you the opportunity to tell us a little bit about your book. So it's called Reshaping Health Systems, What Drives Healthcare and How You Can Change It. It's available for purchase on Amazon, Barnes & Noble, Apple Books, anywhere online. We'll put up a link to it. But go ahead and tell us a little bit about the book. What are the main takeaways, and what are you hoping readers will get out of it?
Yeah, absolutely. That book was a labor of love, many, many late hours. And oftentimes I'm thinking to myself, what did I get myself into? Why did I agree to do this? I am really happy to share about the book, which I wrote with Josh Lau, co-wrote with Josh Lau and John Staloff, who are both colleagues of mine that I've worked very, very closely with over the last few years on a number of projects. It's actually kind of, if you think about the number of things that I spoke about, graduate medical education, health systems, curriculum, thinking about health policy and how all of that kind of comes at a Medicaid level, commercial level, Medicare level, how the implications of that go from the clinic to the hospital, post-acute care, skilled nursing facilities, inpatient rehab centers. Over the last couple of years during coming out of the pandemic, how much many of us were thinking about telemedicine and telehealth, and can we convert this into over Zoom or over the video in some way to make sure that the continuity of care still exists. I think all of these things we were thinking very, very day to day at a scale level. And then the three of us were actually organically working on a number of projects together. And we said, how about if we, instead of, in conjunction with all the work we were doing, if we could make a coherent kind of beginning to finish arc of a patient's journey from, let's say, being at home and then go into an urgent care or an ER, and then being hospitalized, go to a post-acute care facility. And if we could arc an entire patient journey and then talk about some of the levers, or what we call systems factors, that influence that patient's care along with the clinical medicine that they're receiving, evidence-based care that they're receiving. If we could write a story out of that in a vignette form, which comes very, very near and dear to, I think, everyone that gets trained in medicine, right? This would be a really cool thing to do. And I think we initially was like, that might actually not be that hard because we're thinking about this so much anyways. And we kind of pitched the idea to some of the publishers that we were working alongside. And one of them was very, very open to it. And Wolters Kluwer is who we published the book with. And they looked at kind of the outline of our book, which was, again, kind of each setting of care for each chapter. And then the kind of underlying root of it, or what we call systems factor. And a lot of that has to do with policy, delivery care systems, payments, settings, and as I kind of already discussed. And then the second half of the book actually was where we kind of make a little transition. So the first half, we talk about all the underlying root causes. The second half of the book was actually talking about, now you've identified, you've peeled back the onion layers and found out what the underlying cause is. Now, what can you do about it? Potentially within your own practice of care, own practice, clinical environment. And so that's when we introduced some of the principles that I learned very much during residency and during my fellowship, which is QI. How can you identify a specific, a quality metric or a quality improvement project within your own care? How one of the trainings that I got actually at Dell Medical School was healthcare design. We had a design institute for health when Gio and I were there that really thought about, for example, the discharge summary example that I love to share, which is when I still remember being an intern and being told to write a discharge summary. I pulled up a prior discharge summary or other ones that I've looked at from charts. They were so long. You would have to scroll like how much ever, 80 or 90% of it before you got to the actual to-do actions, or the most pertinent high priority items were at like the very bottom of that discharge summary. Where if you're anything like me, I have an attention span of, a 10-year-old. So
everybody these days.
Unless it's at the very top, just the act of dragging your scrolling all the way down was very kind of cumbersome and not very design friendly, user friendly. And so, for example, thinking about how do we redesign a discharge summary template or the format so that it's user friendly, not only for me to write it, but the person receiving end to read it and use it. And thinking about some of the ways that we could do, design and that human-centered design principles into the day-to-day, we kind of incorporated that again as another tool. We talk about kind of change management principles that I think a lot of businesses use to think about how do you change a culture of an office? How do you change the culture of, celebrating small wins, outlining clear goals and principles of a work culture that really lasts beyond just a couple of months and years, and that really conducive to celebrating things and providing really good evidence-based care. And I think these kind of things that people can actually make it into an actionable item was the goal of the second half of the book, to say, let us try to help you understand the underlying causes, and then this is what you can do using tools such as QI, design, change management. And then we end the book with hopefully inspiring people to be able to do some of the things that we've been thinking a lot about over the last couple of years.
That sounds truly fascinating. I mean, I think when I think about my own residency programs, and maybe this is just a feature of how it was introduced to us, QI isn't immediately the most sexy thing to me. But being in practice now a few years, you just recognize the importance of the heart of medicine is really getting at the root factor of a lot of these issues, working in a systematic level to try to provide the best outcomes for everybody. And while it might not be sexy, it's extremely important. And so especially, it sounds like for all physicians across the board, initially this sounded like it might be something that it's internal medicine based, but it's really just understanding systems for the first part, and for the second part, kind of applying that to your own niche and to your own specialty, and, to changing behaviors, including your own. And so I know I'm going to get my hands on it to try to check this book out. It sounds really fascinating. And I encourage other people to go, educate yourself on these issues too, because like I said, we often find ourselves kind of stumbling around with our, in the dark with our hands out like this. And the landscape of medicine is changing in such a way that if we're not in the driver's seat, someone else is going to be in the driver's seat for us and make these changes for us. And
Absolutely.
so we have to take it upon ourselves to be the agents for the positive change for our patients that we need to be. And so thank you again so much for, detailing some of this book. I know it seems like it's really taken a lot of work, a lot of effort. What was that process like, having, we've all maybe done some publishing research articles or something, or a study when we're in residency. And certainly some of us feel like we have to as part of the application process to get into whatever specialty.
Yes.
But how does that compare to, writing this book from scratch and doing a whole new process that you've never been a part of? You've done a lot of that already by creating your own fellowship. What was it like creating a book and writing a book and, doing everything that you've had to do to go through those?
Yeah. What are some of the things that we don't know about, trying to write a book? Like, how did you go find an illustrator, or how did you approach a publisher? How did you get thoughts down on paper? How did you collaborate with co-authors? Did you split chapters? We just don't know any of the details about how one writes a book.
Yeah, happy to share as much as I can. It was a fascinating process. I think you guys, we've been in academics long enough, or been in training long enough, where we're trained on a specific format again, right? You think about introduction, background, methods, discussion,
Sure.
conclusion, and that's kind of the foray of how I think about writing a paper. Whereas it was an open canvas, and what the publishers are really, 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 I really appreciate them more about this, is they trusted us with the content of the book. I think what they asked to see early on was they wanted to see a repeatable format that could be consistent across chapters. Because I think one of the things that is key is you don't want too much variation across every chapter. For example, you don't want one chapter to be 5 pages, then the immediate chapter after to be 35 pages. I think that you want some consistency in how the chapter flows, how the chapter concludes, and in the size and the shape across the entirety of the book, first part and second part. So I think they wanted initially some guardrails around how long should this book be. So I think in total, we had decided that it was going to be somewhere in the ballpark of 250-ish pages when it was all said and done. So when we had that, and then we kind of back solved, when we wrote down all the settings of care individually and all kind of the principles that we wanted to maybe talk about in the second part of the book, we initially divided out to say, okay, that leads us to X number of pages per about chapter. So we had kind of a goal in mind that we wanted to hit on every chapter, plus minus a few pages. Then secondly, it came down to, okay, then diving into each of the chapters, how do we want to bring this as most user-friendly, reader-friendly, and applicable for not only people that are done with training, but people hopefully also at the very beginning of training, or maybe even before training. If you're an undergraduate student reading this, how do we make this possible? And I think that's where we went back to the vignette. We always wanted to open with a vignette to say, this is how the person, hopefully, one very, very real, near, dear to us, because the two of us are internists that wrote the book. One of my colleagues is a family medicine physician. So we were kind of really thinking about, how do we see this in the clinic? How do we see this in the hospital and make it very, very relatable? So we open with that and then do kind of a deep dive into the specific systems factors, and then include at the end of every section and at the end of every chapter, kind of the takeaways. These are the nuggets. If you didn't read anything on the first 20 pages and you get to the very end, just like on Up to Date, right? We all scroll down to the summary and recommendations. It's like, if you didn't read anything else, what is it, the takeaway that we want you to leave with at the end of this book? And we kind of repeat that throughout. One of the biggest challenges, but the commitments that we had, was that we wanted a unified voice throughout the entirety of the book. In other words, let's say we had 12 chapters. We initially discussed as an option, would we want to split 444 chapters across to 3 authors and kind of split it up that way? Or even, across, within each chapter, do you want to write the first half? Do I want to write the second half? And we actually kind of toyed around with multiple of these ideas, but I think what we landed on and committed to was we wanted all 3 of us to have a say on every line of the book. And that was initially, I think, the hardest part. Was we have different styles of prose. We write differently. Even if we talk about the exact same topic, maybe we come from a little different perspective. So unifying our voice, unifying our method of explanation, writing, in first person, some here during the vignette versus the third person here. Just the little details of that, I think, was the hardest part to iron out over the first couple of chapters, to say, okay, this is how each of us are going to have to sacrifice a little bit to unify the voice. And then once we did that, I think the second half of the book, if you will, writing became much more smooth. We knew each other's rhythms by then. We knew each other's kind of who would take the first pass. Oh, you would write the second pass. Oh, I'll take the third pass. And then we huddled together to say, what are some of the things we still don't like about what we have in this section? And so it was many, many, many hours of line editing, copy editing each other's work, some late night Zoom calls that I will not disclose what time of the days. Those were done with many, many cups of coffee and tea. So, I mean, that's what I really mean by, was a labor of love for all 3 of us to try to stick to that commitment. At the end of the day, when we look back, and I think we're super proud of the fact that we stuck to that commitment. There were times when we were running up against the deadline of certain batches of work that I think would have been easier if we just split up the work and trusted each other and say, hey, I'll take this chapter, you take that one. But the commitment that we had, the shared commitment to, from the beginning all the way to the end, it took, I want to say, from beginning to finish, I think the actual writing line by line, every word, took, I want to say, about a year to
oh my gosh,
year and 15 months, to say 12 to 15 months.
It's honestly not surprising, because like you said, it's probably the easiest approach. Like I remember when I did a chapter for a book in publishing in ophthalmology, it's like, oh yeah, you just write a chapter, someone else writes another chapter. But I know that when I go pick this book up, it's going to be cohesive and a good, easy to read. And so I think the audience is probably going to be really grateful to be able to pick up a book and know that, that much love, effort, dedication has gone into it, every word, to make sure that, it's conveying what it needs to convey. So kudos.
Yeah,
kudos
it's a great book. I've read a couple of the chapters. It's very approachable. I like that you start every chapter with a little vignette and you dive into the topics a little, and then you kind of quiz everyone at the end. There's like a couple of quiz questions at the end of each chapter, just to kind of keep everybody honest and make sure you're taking something away from it. In case you didn't know, on Amazon, your book is in the top 100 under the subtopic of health policy. And then it's also ranked 13th under the subtopic of Medicaid and Medicare books. So I don't know if you're tracking that, but that's a pretty big deal. Congratulations.
That's a really big deal.
Thank you very much.
And I really do mean it. I mean, I don't go out and read a ton of books, and that's a personal fault of mine, but I am making it a point to pick this book up, read it start to finish. I encourage, and you mentioned, it's not just people that are in training, finished training, people that are out, maybe have been out 20 years and they aren't as knowledgeable on the systems behind it. But for sure, people going into medicine, you need to know what you're getting yourself into. We've talked about this a little bit in some other episodes in terms of like, what does medicine look like moving forward? And if you don't really understand, if you have this like sexy Grey's Anatomy, like expectation. Maybe that reference is too old of what medical medicine will be like. You're in for a rude awakening. You need to be there for the right reasons, and you need to know what you're getting yourself into. And I think this sounds like a fantastic way to learn a little bit more about that.
Yeah, and on that topic, Joseph, I think we're going to wind down just a little bit, change gears a bit, but what kind of advice would you give, knowing what you know now and what you've been through, to some of the younger physicians out there who are about to enter the workforce and may not be fully cognizant of these issues? What would you tell them? What kind of advice would you give if you could talk to a PGY1 or a PGY2 about some of these things?
This answer I don't think will surprise anyone, but the reason I wanted to write this book, the reason I wanted to pursue, kind of a different kind of fellowship training, if you will, was because I had an epiphany that alongside providing good clinical care and evidence-based care, thinking about the fact that health is actually more often happening for patients outside of the traditional spaces where we provide care as clinicians, and thinking about the underlying factors of an internist asking someone to take 8 to 10 medications a day, even if it's evidence-based, guideline-based for a certain condition. Is that really a practical thing for me to ask somebody, my family, my loved ones, every single day, so that, for 15, 20 years or however long remaining in their lives, right? And so I think, one, we of course need to learn the evidence-based, the most up-to-date studies and the trials to do what's right for our patients, but also taking a step back and saying, what's conscientious way to give this treatment plan? I know the next best thing to do in a vignette is, let's say, get this imaging study or give this medication. But if this was my loved one, or if this was my family member or my spouse or partner, how would I think about this differently, if at all? I think taking one step back to ask some of these questions and trying to put myself outside of the hospital walls or the clinic walls has been some of the most interesting and conducive conversations that I've had with my mentors, some of the trainees that I've had a chance to work with here at UW. And it's actually been some of the most fascinating conversations that I've had here at UW, is because the uniqueness of UW being kind of the academic medical center and the tertiary center for such a wide catch radius here in the Pacific Northwest. So we have patients coming here from, Alaska, Montana, nearby states, where it's a real thing we have to ask ourselves is, once this person goes back to where they're living, will they be able to feasibly continue what they're doing, what we're asking them to do? And so I think thinking about that medicine doesn't stop at the walls of a clinic or traditional walls of a hospital, but how we provide and nudge people once they leave, I think is just as important in their training.
Completely agree. Definitely have to put that into practice in any specialty that you're in. And I think about that too. What's cost effective for my patients? Same thing when you approach this patient, they might be a ticked off patient that's angry and frustrated, and you have to put yourself in their shoes. Always think about the golden rule. It's like, why are they feeling the way they're feeling? Even if your initial reaction is to be reactionary and be like, hey, why is this guy mad at me? I'm trying to help him out. How can you disarm that? And how can you put yourself in their shoes, even if they're angry at you, so that you can essentially treat them the way that they deserve to be treated and that you'd like to be treated? So one kind of final question, this is a kind of a fun question that we like to ask everybody. We know, even though you're very passionate about what you do, your whole identity isn't to be in medicine. Your whole identity isn't just to be a physician. You have a lot of degrees and elements and identities. And so if you were not practicing medicine and making this radical change, I mean, clearly writing is something that you're great at, but what would you be doing outside of medicine if you had to choose something?
And not engineering, obviously.
Ophthalmologist. I'm just kidding. I actually thought about this recently. I do love to read and write, as you know, hence I wrote a book with several of my buddies here. But I think a different passion of mine that I have, and something that I think a lot about, is sports, and some of the principles of team building within sports. How, sacrifice to achieve a common goal together in sports is something that I am fascinated by. The complexity of some of the sports that, Gio and I talk about, whether it's football or basketball, is also, as a nerd myself, I think about quite a bit. But I think more deep than that, I would think if I was not in medicine, I would have maybe pursued a career in like journalism, or like a columnist, to really dive deep into a story, right? And I know there's different ways and different mediums now to share stories. There's clips of videos that do like short documentaries. Obviously, someone could start a blog online or have, more of an official column within a newspaper. But I think diving deep into a story that maybe people not know about from all perspectives, and then being able to not necessarily take a side, but just to educate people online on a passion of mine online. And so in sports, whether there's a team that I love or a team that I follow, like going deep behind the scenes to say, yeah, we like celebrate somebody winning a game or a championship or having an incredible season, individual season or a team season, but what are some of the behind the scenes tensions that happen that no one knows about? And then a couple years later, you're like, oh shoot, like this was a personal struggle, or coach was going through XYZ. This player had an injury that no one knew about, but then, they were still looking out for each other, had a common shared goal and achieved this. And I think those are some of the documentaries that we see now on Netflix, right? The one with Michael Jordan, The Last Dance. Everyone celebrates the championships, but you're like, oh my goodness, that was what Dennis Rodman was doing? Or
what happened?
Yeah, what happened?
I'm very excited to watch like all the 30 for 30s by Dr. Joseph Jew, because it sounds like you'd be like in the heart of it, just telling us like the truth behind any given issue.
If I could do a 30 for 30 for medicine, that would be my alternative career. There you go. Yeah.
All right. One final question we want to ask. I know you don't have any kiddos, at least not yet. I think actually based on a lot of the changes that you're trying to make in medicine, it makes it seem like a different landscape. But if you had a kiddo right now, do you think you would possibly encourage them to go into medicine?
I really would. I have found this career. Now, caveat that is I haven't been doing this for too long. But I think some of the changes that I see happening are, I think, exciting. Some more than others. And I've been fortunate enough to be part of some of the change here at a policy level at the state of Washington, and then also trying to encourage and nudge the next generation of trainees to be able to make change on their own. And I think in that same breath, if I had a kiddo of my own someday, I would sober him up as much as that advisor did for me in undergrad from the get-go, to say, know what you're getting yourself into. I'm not going to beat around the bush. This is the landscape. But it, I think, provides an incredible foundation, and it opens so many doors, whether it's clinical practice, policy level, administration, or some really cool business opportunities. And I've found it to be just a foot in the door to so many interesting conversations and people that are willing to listen and care about what some of my passions have been. So I really would. I hope that doesn't change too fast in the future, but I really would encourage my kiddo.
You've clearly found your passion, right? And it comes across very genuinely. And I think that, if any of us are lucky enough to find our passion in our field, then obviously we would recommend it. It's just the reality is some of us, never really find the level of fulfillment in our careers that you've found. And so I think that your message is really going to resonate with some people who are thinking about the same things that you're thinking about and are motivated by those same things. So we really appreciate you spending this afternoon chatting with us, Joseph. It's been really, really great catching up with you. Looking forward to seeing the success of your book. And
thank you very much.
You're on a rocket ship, man. I think you have such a bright future ahead of you. I can just tell talking to you. And so thank you so much for coming and speaking with us today. I think our audience is going to love listening to what you have to say today.
Yeah, thanks, Joseph.
No, thank you guys. Please say hello if you guys are ever in Seattle, and then I'll give you a shout out next time I'm in Texas.
Let's do it. Thanks, Joseph.